Hi, everyone. Good evening. My name is Annie Benzie,
Good
and I am the.
morning. Afternoon.
Oh, hello, Dr. Dayaraja with your pink tie. Perfect. My name is Annie Benzie. I am the chair of the fellow subcommittee for the SSAT Complex GI Surgery Fellowships. Welcome, everyone, to our grand round session for April. We have a great talk tonight. And I just want to say thank you so much for everyone for being here in attendance. Just a reminder before I forget, DDW is coming up. So today is actually the last day to get your housing guarantee. So please, if you haven't already registered and signed up for that, please do so. It's going to be a great meeting. Lots of interesting discussions, such as one by Dr. Jayaraja himself, trying to keep the peace with that discussion. I'm looking forward to it. And I would like to introduce Dr. Margot Mustian as our moderator this evening. Thank you so much for agreeing to be here as well. She is an assistant professor in the Division of Gastrointestinal Surgery at University of Alabama. And I would like to have Dr. Mustian give us a little commentary and introduce our fellow.
Yeah, well, thanks so much. Yeah, I'm so happy to be here with everyone tonight. Thank you all for joining in as we talk about novel techniques in bariatric and metabolic surgery. Dr. Patel from University of Maryland is going to be giving a talk for us, and obviously we'll encourage a lot of great discussion along the way. So go ahead and you can kick it off for us.
All right. Well, thank you, everyone. Good afternoon. As was mentioned, I'm speaking about novel techniques in bariatric and metabolic surgery. I'm currently the MIS fellow at University of Maryland Medical Center. Oops. See. Okay. So just some objectives for the talk. First, we'll try to understand the epidemiology and the impact of the obesity epidemic, both here and around the world. And we'll briefly review the advent of bariatric surgery, its early struggles, and the early history of it as well. We'll discuss the current trends in the field and discuss kind of where the field is going in the next decade or so, and the new techniques that have been developed. And then finally, we'll go over a few case scenarios. I have no disclosures for this talk. And then here we just have some outlines, just brief history, current practices, as I said, new techniques, and the future of the field. So the impact of obesity, as we all know, it's steadily rising. It accounts for almost 42% of US adults are classified as obese, having a BMI of over 30. Severe obesity is also on the rise and affects over 9% of the adult population. And even in childhood, despite a lot of effort, it continues to rise, impacting almost 20% of children aged 2 to 19. And it's rising across all groups, both racial, socioeconomic, and geographic. And as you can imagine, there's a direct annual healthcare cost to all this obese patients and their comorbid conditions that is estimated to exceed $173 billion annually. Um, Individuals with obesity incur about almost $1,800 or more in annual costs compared to those who are not obese. And these patients are mostly Medicare and Medicaid patients, so these programs bear most of the financial burden. In terms of quality adjusted life years lost with obesity, just with mild obesity, the estimated life years lost is 2 to 4, which only goes up as your obesity worsens. And it's also linked to reduced lifespan. They on average live 5 to 10 years shorter than in severe cases. And it's been shown that quality adjusted life year loss arises both from chronic disease burden as well as reduced functional capacity. Oops, sorry, wrong way. And so these are the rates of obesity around the world. As you can see, the US stands currently at number 2, just behind Egypt. And it's increasing everywhere. There are a few select places where, you can see it's not. Somehow France has kind of figured out how to stave off obesity. I looked into it a little bit. It's actually, the government there is really pushing early awareness and education in the younger population. So I think starting from a young age, that's the main way that we can stave off rising obesity rates rather than trying to tackle it after it develops in the population. And then just broader impacts in terms of comorbid conditions. Obesity contributes to 30% of type 2 diabetes cases, 20% of cardiovascular events, and has been shown to cause elevated risk for 13 different cancer types. And of course, there's a lot of productivity loss from all these comorbid conditions that adds another approximately $66 billion annually. So this kind of brings us to bariatric surgery and kind of what's going on with it and how it first developed. So currently, we perform about 280,000 procedures here in the United States. This was a couple of years ago, but that number is steadily increasing. The vast majority of it is laparoscopic, but of course, robotic cases are rising as the robot is becoming more widely available and adopted by current surgeons. And then a small percentage are performed open, usually as either a conversion or a salvage operation. And like I said, these rates are rising year over year. Most of these procedures are primary, and then there are a small percentage that are revisional, mostly due to weight regain, GERD, and then other complications related to bariatric surgery. And so if you'd go to the advent of bariatric surgery, this is the first reported case, which was done on April 9th. We're almost celebrating the 71st anniversary just now of what's considered the first bariatric procedure in the United States. It was by Dr. Kremen and Linner. This is at the University of Minnesota. And they performed a they tried a jejunocolic procedure, which didn't end well for the patient. So they transitioned to a jejunal-ileal bypass. You can see the anatomy of that operation. You simply disconnect the jejunum from the ileum and then do a end-to-side anastomosis with a very short common channel. They presented this work at the Cleveland American Surgical Association in 1954. But as you can imagine, their first patient actually did have several complications, including a GI bleed, first inadequate weight loss, which is kind of surprising, and it eventually did have a reoperation for that. And so this is Dr. Linner, and after he performed this procedure, he was kind of looking for some support around the University of Minnesota, and there was another big wig there. This is Dr. Ansel Keys. He's actually known for developing the K rations, which is what World War II soldiers used as their rations, and he was a developer of this, and that's why it's called the K ration, K for Keys. And so he actually went to Dr. Keys and said, "Well, what do you think about this, new procedure that I came up with?" And this is kind of the famous quote he said that Linner later described, said he was listening attentively to my description of our surgical approach for treating extreme intractable obesity. However, he was not at all encouraged. In fact, he said, if any surgery was to be used for obesity, perhaps it should be to sew the mouth shut. So like all scientific endeavors, this one was met with ridicule at first, but then later gained a little bit wider adoption, mainly by Dr. Payne here. He kind of took the reins from Dr. Linner and began doing these jejunal bypasses in patients. But unfortunately, the procedure did not have the safety profile that was acceptable. Most of these patients had severe protein malnutrition, vitamin deficiencies, and ultimately developed liver failure. And then the entire procedure was abandoned eventually. And this is a quote from Dr. Payne, but essentially he says that these procedures should be done in specialized facilities that are equipped to handle these patients and their complications. But you can tell from his quote here that he was not a huge fan of the procedure by the time he had studied it extensively. And so the field kind of moved on from there. The gastric bypass was introduced in 1967, which was kind of the foundation for the modern Roux-en-Y procedure that we do these days. There was a brief foray into banded gastroplasty and gastric banding, which started in the 1980s. And then the sleeve started being done in 1988, first as a first stage of a duodenal switch. And then bariatric surgery really began to pick up with the advent of laparoscopy. with minimally invasive approaches, the safety profile was greatly improved. Um, the hospital lengths, stays were much shorter. There was less pain, and so it was really started to gain steam around the 90s and the turn of the millennium. And then finally, today there are different types of approaches and new techniques that are being developed that we'll kind of go into, that will kind of usher in probably the next wave of bariatric surgery.
I think it's really important kind of going back. I think it was nice how you kind of went through the history of bariatric surgery because I think it helps us kind of understand our patients' perspectives on surgery, kind of knowing the previous concerns with safety and efficacy of the operation, and obviously a lot of changes in the 1990s and 2000s. But certainly, I think there's still a lot to overcome in the current era, kind of thinking about kind of what led to the pathway for bariatric surgery currently in the U.S.
Absolutely, yeah. And I think that's kind of what's fueling this next stage. Even though we kind of have some procedures that we're all very comfortable with and we know that work, there's still a push to try to move the field forward, to try to personalize the field for each and every patient. And so these are the most common procedures that we perform these days. Of course, this is not an exhaustive list, but the sleeve gastrectomy is easily the most commonly performed. It's about 60% of current procedures. It has an expected excess weight loss of 50 to 60% around 2 years. The common complications, of course, is leak, and we know that it can worsen GERD, and especially in patients who have symptoms of GERD pre-op. The gastric bypass has been around for a long time. It makes up about 20 to 25%. You get a little bit better weight loss with it, compared to the sleeve, but it is associated with dumping syndrome and other micronutrient deficiencies, given that it's a malabsorptive procedure. And then less commonly, you see the duodenal switch and biliary pancreatic diversion. These are generally reserved for one, surgeons who are comfortable performing the procedure, but also higher BMI patients and have more of a metabolic syndrome because this procedure tends to have better rates of remission. And then gastric banding is essentially abandoned now. It's rarely performed. There was a lot of one, there's suboptimal weight loss compared to modern techniques, and then the complication profile is not as acceptable either. I think nowadays we remove more than we place, in general.
Yeah, I'm actually kind of surprised it's still listed as current practices because I feel like it's really gone.
Yeah, it's essentially gone, but we do see it, and we've removed a fair bit of them, and continues to be um, just relevant since that that there's a lot of patients running around with these bands still. And so these are some of the emerging techniques. And again, this is not an exhaustive list. There are several different variations of each one of these. But the main ones I'd like to talk about are the SADI-S, which is a single anastomosis duodenal bypass and a sleeve gastrectomy. This first kind of started in the 2010s. It combines a sleeve gastrectomy with a single loop intestinal bypass. There's also an endoscopic sleeve gastroplasty. This is a completely endoscopic bariatric procedure where the stomach is plicated, reducing the volume and creating a restrictive weight loss. There is a one anastomosis gastric bypass, which again uses a loop, and instead of dividing the bowel to create your Roux-en-Y, you just make one anastomosis of the loop. Then there's also a single anastomosis sleeve ileo bypass, which I'll also get into, which is kind of a hybrid of a sleeve and an ileal bypass. And then finally, I have on here a sleeve gastrectomy and a transit bipartition, which is similar to the sleeve ileal bypass, and I'll kind of get into the nuances there, and kind of the science behind it. But this is kind of what I'm going to be talking about. So next question is, why does this matter? So, a lot of us aren't, or at least all of us are not going to become bariatric surgeons, but um, it's important to understand the management of these patients because as more and more patients receive these procedures, they will all come with complications, and a lot of them don't present back to their bariatric surgeon with their complications. They end up at a local hospital where there's a general surgeon taking call. And this was a study I found. This is just in Ontario, Canada, but in this survey, about 25% of their surgeons said they don't feel comfortable dealing with bariatric complications. And 67% of surgeons agree that managing these complications should be within a general surgeon's skill set. So I think it's important to understand these new and emerging procedures so that general surgeons are capable of handling acute problems and delayed complications from these procedures.
Yeah, I think you bring up a good point there. We typically have a talk kind of once a year for general surgeons in our area to kind of help manage bariatric complications. And I think it can be challenging because even if, certainly at our institution where we do a lot of bariatric surgery, we're still dealing with a lot of referrals from other areas or maybe patients that have had complications elsewhere.
Mhm.
But there's not always beds or there's not always capability of getting patients back here. So the more that people in the community or people that are not even doing bariatric surgery are familiar with it, I think the better, just because I think it's the best for patient care too. Certainly for some more nuanced care, obviously getting back to a bariatric center is important, but just for
Mhm.
basic management is really important.
So,
Yeah,
if I
agreed.
could just jump in over here, I think that's a really good point about being able to manage these complications. I have to say, sometimes it's not easy, especially in internal hernia, to figure out where things are going. And I was wondering, Dr. Martin, if you have any suggestions. I mean, I typically start from the cecum and move up. That seems to
Yep,
be the best way for me to do
it
it.
is.
But sometimes I still feel like it's in a complete twist, and I'm completely vulgarized. And I just was wondering if you have any hints for somebody who's not very good at this, i.e., myself.
Yeah, I think like you mentioned, starting distally is always the best thing. And a lot of times you'll end up reducing the internal hernia as you're mobilizing the bowel that way. So I think that's obviously definitely the right way to go about it. Then once you kind of have everything, if you just keep marching proximally from that distal end, eventually you'll get to your JJ and then your DJ and then kind of be able to look at Peterson's space and attack that there. But I think like you said, yeah, starting distally, working way proximally is definitely the best thing. And then just keep looking at it and kind of keep manipulating the bowel until things start to look more normal. But as long as you've pulled it that way, it should all be reducing. And you may not even see it reduce as you run the bowel.
Perfect. Thank you so much. And Dr. Patel, I just want to give you some historical background. So it's really interesting with the JI bypass because they typically would just plug it into the transverse colon and they'd
Mhm.
have just profound, bypass issue. The problem with these is reversing these is really, really challenging because your discontinuous limb has bacterial overgrowth. And
Yeah.
so what I learned in this procedure when you reverse these is to put a feeding tube into the bypass limb first and
Mhm.
just feed it.
Mhm.
Because if you try to put everything back together again, what you end up with is profound acidemia because the bacterial overgrowth causes actually a D-lactate, not an L-lactate, which is what we measure. And so you end up with this disastrous, situation of getting everything in continuity. So what I have learned, I mean, again, N of like 5, it's not a ton, but is to put a feeding tube into that bypass jejunal limb and feed it up and then reverse them after that. And as you know, a lot of these patients need liver transplants because they die of fibrosis and fatty liver. And the question is, do you do the transplant first or do you do the reversal of the bypass first? And that's always a challenge. My last historical fact, since I think I'm probably the oldest person on this call, is when the lap ban came in, I was like, oh my God, we did this already. We did this with the VBG. Why are we doing this again?
Mhm.
It's a purely restrictive procedure. And so it's been interesting to see that actually pan out to be true. But the VBG was sort of one of the biggest things that was done in the 80s. And so reversing those is also a challenge. I generally do that as a gastric bypass. Is that what you do, Dr. Mustin? I
Yeah.
usually just use that vertical, that pouch and do a bypass to it. Is
Yeah.
is is
Yeah.
is, is that how you handle it?
Yeah, that's right. Yeah, same way. And I think it's interesting how you talk about the band too. I think it's interesting that we kind of try things over and over again that are essentially the same idea, but hoping for a different result. I think that's certainly where we ended up with the band. And I think even, with bands taking them out later, can potentially do a sleeve later or a bypass later with the bands. It just depends on kind of what their anatomy is and kind of what symptoms that they're having too. I think if you could just get the band out first, and kind of give them a chance to recover, kind of see what their function is going to be like, and then you can kind of see what they need.
Yeah, no, thank you so much. I just wanted to throw in a couple of historical
Yeah.
vignettes there.
Yeah, thank you.
Sure, thanks. So I was gonna next go into kind of detail about each of these procedures, starting with the SADS. Again, it was first performed in the 2010s. And essentially, this is a sleeve gastrectomy and then a single anastomosis from the duodenum to the ileum. And then there's different common channel lengths, but it's generally 250 to 300 centimeters from the IC valve. And it's basically a simplified form of the duodenal switch. It works by both restriction via the sleeve and then malabsorption from the loop bypass. And this also enhances GLP-1 and incretin hormone release and improves improves insulin sensitivity and promotes satiety. And I'll get into a little bit of the endocrine hormonal signaling that goes along with that in a little bit. Um, and then weight loss this is probably a little overquoted, but um, it's similar to a bypass, essentially. It's around 60 to 70% at 2 years. And then complications, the same ones you would imagine for a bypass. You can get protein malnutrition, vitamin mineral deficiency, steatorrhea. And because it's a loop bypass, you can get bile reflux. And I'll show you the anatomy essentially. So this is what it looks like. You do a sleeve gastrectomy, and then you actually transect you preserve the pylorus and transect the duodenum distal to the pylorus, and you actually perform your loop anastomosis to the duodenum. This has several advantages. It does have reduced rates of bile reflux because you do preserve the pylorus, but there still is a certain rate um, uh, of reflux that you'll get. And then obviously you're bypassing a segment of the intestine, so you'll get some malabsorptive effect as well. There's limited dumping with this procedure as well because your food bolus is essentially entering the duodenum. There can be an argument made if this is good or bad. Some amount of dumping can be good only because it kind of deters patients from eating high caloric or high sugary, high carb foods, and that can actually help with their weight loss. Um, but in terms of the patient experience, I would say that, this is not a desired effect. And then this all obviously has one fewer anastomosis than gastric bypass, which is kind of the main advantage for surgeons. It's a little bit simpler to perform compared to a gastric bypass or a duodenal switch and with comparable weight loss. And so there's been some studies is if to see if this is actually better than what we have. And I found this study, which actually looked at the um, MBS QIP database, and this looked at 30-day outcomes of SADS compared to Roux-en-Y gastric bypass. This is a retrospective study, so it's not a randomized trial or anything like that. But this is what they found, which is kind of interesting. So you can see right off the bat that the SADS has a higher complication rate. Both are all in anastomotic leak rates, reoperation rates, sepsis, and mortality. Now, obviously, like I said, this isn't randomized. So, and they did comment that the SADS patients tended to have higher comorbid conditions. So there's probably a little bit of selection bias going on here. But I was a little surprised to see that, the SADS, even in renal failure, pneumonia, things like that, was having higher complication rates. And I think part of it could be surgeon comfort. This is a new procedure, but gastric bypass has been around for 40 plus years, whereas this is not. So I don't think that, surgeons are as facile with this procedure, and that might play into this. But it's
Yeah.
interesting to look at.
One thing I would say, we don't have table 1 included from this paper, but to your point, there was definitely a difference in the patient makeup between the two groups. Now, obviously, that'll be accounted for a little bit more, I think, in your next table, but I think it was, I can't remember the difference in BMI, but I think it was about at least several point difference, maybe even 10-point difference with the two groups. And then other comorbidities were much higher in the SADI group compared to the bypass group. So certainly kind of looking at apples and oranges as far as the patient population. I think there's some other smaller studies that had a little bit of a different outcome. And I don't know if for those, if they were matched cohorts or how they had put their groups together. Well, that's just something else to think about. Obviously, you can kind of spin this data any kind of way, but I will say for this one, it seemed like it was kind of all comers, whereas maybe some other smaller studies maybe would have cherry picked their patients.
Mhm.
I don't know. It could kind of bias you either way, but I think it's
Yeah.
just important to kind of take the results of this study kind of in light of all the other studies that kind of looked at this too.
Yeah, absolutely. I think this is not, you have to take all this with a grain of salt. A lot of this data is new, there's no long-term data on this stuff yet, because it's just been starting to being studied. So, and then the next table I just also found interesting. They just had an odds ratio of 1.45 for a serious complications for the CADS compared to the bypass. But again, this can all be explained by confounders or selection bias. So I think it warrants further studies, and I think randomized trials might elucidate this a little bit better, or prospective studies at least.
So I have a quick question
I
too.
think
Going
that
back
was,
to go ahead, Dr. Masian.
I think at least in this table, it at least accounts for other patient comorbidities that the other
Yeah.
and the other table doesn't. So I think that does kind of lend a little bit more credence to it. But again, that being said, it doesn't really affect the fact that selection bias might still be there. And yeah, go ahead.
Mm-hmm.
So a quick question too. Going back to like the emergency general surgery part two, where usually for the CADs, where are the leaks? Do they comment on that?
I don't believe they did, but I mean, it's either leaking from your sleeve staple line or your anastomosis, or I guess potentially your duodenal stump. But I think most of them come from the anastomosis. I think that's what they had mentioned in the paper. I have to double check that though.
Because it's definitely something I feel like non-bariatric surgeons would be difficult to get them to take care of that issue, right? And then Dr.
Absolutely.
Jayaraja,
Yeah,
Dr.
just a quick
Jayaraja.
question. How long is your pancreatic or biliary limb in this case? Do you try to make
Uh,
it long, or, whenever we do like a regular B2 or anything like that, we actually keep that limb very short.
Very
But in
short,
this
yeah.
case, when you're trying to actually achieve some weight loss, is that part of it to bypass that section?
Yeah, I mean, your afferent limb is certainly longer than it would be in a B2. I couldn't find any quoted, standard lengths that people use. But I think,
But
just
you
based on
did
what we,
Yeah, but you did find that 200 to 300 centimeters of a common channel,
for
so
the
you're kind
common
of aiming for that,
channel,
right?
right? So
And
you
thank
could
you for
estimate.
making that point. I think it's really important that everyone understands it's not the length of the roux or the length of the pancreatic biliary limb. It's actually the length of the common channel that you really want to focus on, right?
Right.
Dr.
Yeah.
Martian, is that kind of what you do? Try
Yeah.
to aim for 200 to 300 centimeters?
Yeah. So yeah, my a full disclosure, I actually don't do CDS, but I will say yes, the approach to it is usually 200 to 250 centimeter common channel
Okay,
is the most
perfect.
common.
Thank you. And just I put this in the chat, but Dr. Marcian, there was a big thing about sweet eaters and non-sweet eaters in the very initial days of bariatric surgery. Is that still a thing? Because we used to like the sweet eaters to have a sort of some sort of bypass phenomenon because of the dumping that results in that. Whereas the purely restrictive operations, you can suck McDonald's milkshakes down all day. What are your thoughts with regard to that?
Yeah, I think that brings up a really good point. I think um, the historic, I guess, ideas behind that I think are still there. So I think some people would maybe push patients towards one or the other based on that, but I don't take it into account as much. I really try to get all patients to avoid sweets if possible, or definitely minimize that. And so I kind of do that across the board and don't tailor that as much, I guess, as far as which operation to choose, but certainly something to consider too.
Okay. All right. And then just current trend, I was trying to look to see, whether CDS was gaining popularity or not in the recent years. And I couldn't find much, but it looks like in 2021 there's at least 1,500 recorded cases, and in 2022 it kind of dropped off a little. Um, I'm not sure if that's just a fluke or what, but I think it'd be interesting to see where the trend has been going for SADS. And right now it only accounts, at least for the most recent data, only accounts for 0.6% of all bariatric operations in the US. So I'll move on to the endoscopic sleeve gastroplasty. This is first developed in around 2013. So this is a completely endoscopic procedure, does not require any incisions, and essentially it's done by an advanced endoscopic surgeon or GI doctor, but essentially they take full thickness endoscopic bites of the stomach and tie it down to plicate the greater curve of the stomach and tubularize the stomach. It's primarily restrictive, promotes early satiety, does not involve any resections or staple lines or anything like that. Weight loss is slightly less than what you would normally see in a sleeve gastrectomy, say. Only about 15 to 20% of total body weight loss, which um, the sleeve you can probably achieve closer to 25-30% of total body weight loss. This was another thing I found kind of frustrating. The weight loss that was reported in all these different studies is all different. Some people use excess weight loss, some use excess BMI, some use total body weight loss. So it's just important when you're reading these studies to really compare make sure that you're comparing the same measurement and making your judgments based on that. Um, and then complications are fairly low for this procedure, given that it's minimally invasive, but it's not as effective compared to a true sleeve gastrectomy. And so this is kind of a diagram of how it's done. It reduces the stomach length and volume by 50 and 75% respectively. And they're taking full thickness bites. And essentially they take a bite of the anterior stomach, the lateral stomach, and the posterior stomach, and then tie it down in an interrupted fashion, and then run the suture. I'm sorry, it's interrupted sutures, and they basically run the do several rows of suture all the way up to the fundus of the stomach to placate the greater curve and create the restrictive effect. And so I found this study was actually a systematic review, which compared the gastroplasty with the sleeve gastrectomy. Looked at 5 studies, 1,400 patients versus 200 patients, and you can see that these studies reported total body weight loss, but the gastroplasty has achieved 13 to 15% weight loss, whereas the sleeve was able to get up to the 20s, 23 range at 6 months. The complication rate was lower for the gastroplasty group compared to the sleeve group. However, they're only reporting clavia dindo 2 and 3 complications only. So it's an interesting technique. I think might be useful for patients who are not interested in surgery or have a hostile abdomen where the risk of the operation would be too high. And so this provides an alternative. And then you can see the advantages. There's no abdominal entry required. And I forgot to mention it is reversible, so they can go back in later if needed and cut those sutures, and you can gain some of the stomach volume back, although there probably is an element of scarring and fibrosis that may not allow the stomach to fully expand. Fairly low complication rates, and then it can be used provisionally for failed sleeves as well. And then the main disadvantages, there's modest weight loss, um, hiatal hernias and other gastric pathologies such as ulcers can be a contraindication. It's not approved by most insurances, and then it requires advanced endoscopy skills for the suturing.
Yeah, so I guess we can pause here for a second.
Mhm.
Go back one slide if you can.
Sure.
So I think ESG is really interesting because I think it has some promise in the fact that if we could use it for patients who are not great surgical candidates for maybe hernia repairs or things like that to kind of get them to their, the weight that we want them to be for their optimal hernia repair. However, one of the tricky parts of that is the insurance coverage. There's really not a lot of great insurance coverage. It's not covered at all here in Alabama, at least.
Mhm.
So it would be out of pocket, and I think that tends to be really challenging for patients. Um, there was a comment about how it compares to GLP-1s. I think that's a really great question too. So I used to previously think of this as a great option for people that didn't really want an operative approach, didn't want any incisions at least, but wanted weight loss. But I think for those patients that have lower BMIs where they would also see a benefit from this, I think GLP-1s are actually probably going to fit that bill pretty well. So I think we'll have to see. I think the verdict's still, I think, on that. But certainly, I think there's going to be a lot of overlap between patients that would benefit from this versus GLP-1s, especially if it's weight loss for a certain for another operation, or for patients that are just trying to avoid any operative intervention.
Sure.
I think the other important part though is the more that we can kind of take over management of this is, the better, because I think a lot of for like advanced endoscopy skills, one of my partners is pretty facile with this. And I would say that the more that we can keep that within the surgical realm, I think the better, because I think otherwise we kind of go down that slippery slope of losing kind of management for the bariatric patients. And then also kind of similar with, the fight between cardiology and cardiac surgery. So I think the more that we can kind of take care of patients from a multifaceted approach, the better. However, certainly we'll see how this all plays out. But I think this is something that as surgeons we need to really invest in right now.
Okay. Next, I'm going to talk about the one anastomosis gastric bypass. This was first described in 1997, but gained broader use in the 2010s. Again, this is very similar to the bypass in that you create a gastric pouch, and then a single anastomosis GJ is performed, usually about 150 to 200 centimeters from the ileocecal valve. This works by both restriction and malabsorption, similar to the Roux-en-Y gastric bypass. Excess weight loss is comparable at 2 years. Risks and complications, again, bile reflux with your loop anastomosis, still have the risk of marginal ulcers, nutritional deficiencies, um, uh, and things like that. And so this is the anatomy of the one anastomosis gastric bypass. Again, you create your pouch, and then a loop anastomosis, just a single one here. Again, you can imagine, just given this anatomy, that again, you're still going to have risk of marginal ulcer, and you have risk of bile reflux since you have a direct path for the biliopancreatic limb to the gastric pouch. And the main advantage of this is that it, again, is one anastomosis. So some surgeons feel, just more comfortable performing one anastomosis in certain situations. And then if you look at the efficacy and the safety compared to a Roux-en-Y, this is actually a randomized trial. They randomized 256 patients to Roux-en-Y or one anastomosis. The excess BMI weight loss was what they reported here, and again, it's comparable, a little bit higher in the one anastomosis group, but 75 and 71%. They both had similar nutritional deficiencies and diabetes remissions. However, the one anastomotic group did develop GERD at a higher rate than the Roux-en-Y group. My best guess for that is that they have a higher rate of bile reflux, just given the anatomy of their bypass, and I think that kind of manifests itself as GERD-like symptoms, where you wouldn't have that in the Roux-en-Y group. And then they did mention that about 8% of their one anastomotic group needed conversion to Roux-en-Y for serious adverse events, although they didn't really specify what these events were. And then I'll go on and talk about sleeve gastrectomy.
Can I just ask about this? Because one of the things that
Yeah,
was
sure.
brought to my attention very specifically with this operation, which I think you've really shown beautifully, is that you actually want to create a longer and a slimmer pouch and make the
Mhm.
anastomosis at the base of it. I
Yeah.
always, whenever I do this, I'm not a bariatric surgeon, but whenever we deal with this type of thing. I always thought you want to keep that pouch really high up so it doesn't expand because you don't have, fundus. And second of all, you don't have acid production so that you don't have a marginal ulcer. This would seem to me like that would be the major issue over here. But is that kind of what you're trying to do with this operation? Or am I misunderstanding that aspect?
From what I understand, yeah, the construction of the pouch is a little bit different compared to a Roux-en-Y gastric bypass. It's a little bit longer. The bypass tends to have a pouch about 30 milliliters or so of volume. But this is a little bit longer. I couldn't find any real description as to why that is. It may be just the technical issues of trying to bring up a loop, although um, I'm not entirely sure of why the anatomy is different or the pouch anatomy is different for one anastomosis gastric bypass.
Dr. Mastian, do you want to comment?
Yeah.
Thank you, Dr. Patel.
Yeah, sure. So I also don't do these operations either. I think they're pretty uncommonly performed, but that being said, I've also heard the same thing about the size of the pouch, but I don't really know the rationale behind it. Certainly something that we could look up and kind of share with everybody later too.
Yeah.
Mhm.
Dr. Clement, did you have a comment?
Yeah, I did. So if you ask Robert Rutledge, is
You're cutting in and out, sir.
Yeah.
can you hear me?
Yes.
Much better.
Okay.
Can you lean forward? Lean forward.
Lean
Dr.
forward.
Yes, there
You
you
want
go.
a long, skinny pouch.
Why?
And that, according to him, it reduced the reflux rate. So bile reflux rate is lower with a long, skinny pouch based on the lesser curvature. You get less stretch on the pouch because it's more muscular. So over time, it doesn't stretch out and you reduce reflux.
How about acid production and marginal ulcers?
Yeah, I can't speak to that. This operation is really problematic. The first gastric bypasses were actually loop gastric bypasses like this one. And the controversy that Rutledge created in the early 2000s was really magnificent. So I'm not sure too many people are doing this operation.
I think that kind of goes back to the beginning of our talk where we try similar things over and over and have, find similar results along the way too.
Absolutely. Okay. Remember this already? Okay, and then next one is sleeve gastrectomy with transit bipartition. This was kind of an interesting concept, and Dr. Santoro, who wrote the paper on this, actually went into kind of the science behind it, which I found kind of fascinating. And he really described how, GLP-1 signaling was better or how it was enhanced by this bipartition anatomy. But essentially, this is a sleeve gastrectomy, but it has two gastric outlets, one artificial that is made through an anastomosis, and then the duodenum and the pylorus is still in continuity. And so in this type of operation, the food reaches ileum faster, and this enhances GLP-1 secretion, and you get all the positive effects of the improved insulin sensitivity, as well as the GLP-1 secretion, early satiety, and things like that. Again, there is some degree of nutrient malabsorption, but because there are two pathways for food to take, you actually maintain bowel length just because some food will go through the normal, the duodenum and through the normal pathway. Weight loss with this was comparable to, the Roux-en-Y gastric bypass, but they also had very good remission rates for diabetes. The issues with this operation was that it was technically complex and it required experienced surgeons. There's obviously risk of internal hernias and nutrient deficiencies as well. Let me just show the anatomy real quick. So this is what it looks like. So it's a sleeve gastrectomy. And then you'll divide the small bowel and then bring up essentially a roux limb to the sleeve. but you're leaving the duodenum and everything in continuity, and then your biliopancreatic limb you anastomose distally. And so you can see that the alimentary limb has two pathways to take. And he goes over the kind of the rationale or how this works, which I think is interesting. So essentially, he argues that our intestines are too long for modern diets, and that this is the reason that the modern obesity epidemic kind of exists. Um, because of the rich overprocessed foods that we have nowadays, essentially the foregut gets intense stimulation while the hindgut gets very little stimulation. And that kind of leads to less GLP-1 and PYY secretion, and that causes increased gastric emptying and decreased satiety. And he kind of argues that this is the reason that, obesity kind of balloons in modern times. And, you know, in prehistoric times, primitive humans and animals consumed, currently animals consume an unprocessed diet, which leads to more even stimulation of the entire GI tract, and leads to better satiety and insulin sensitivity because the hindgut is stimulated just as much as the foregut. And so the transit bipartition tries to reproduce this effect. Um, Basically trying to introduce a new food bolus directly to the ileum while also preserving the absorptive effects of the foregut. And so I think that's why his results were pretty good, both with diabetes remission and weight loss. And you can kind of see that, um, herbivore animals have very long intestinal length compared to their body length, as well as surface area. And as you move down towards the carnivores, your gut length becomes shorter and shorter. And essentially, humans have a pretty short gut. But since we eat such, in general, high processed foods and rich diets, we kind of need an even shorter gut to try to minimize the effects of obesity. So simply, our guts are a little too long for the kind of diet we eat. And so his bipartition tries to mitigate that. And I just thought it was an interesting how he tried to explain, the way that his operation works. And he also describes the unique advantages of his operation. Like I said, it maintains and even improves endoscopic access. So you still have access to the duodenum and the biliopancreatic limb, but you also have access to the ileum. And actually, two of his patients were diagnosed with the neuroendocrine tumor and a GIST postoperatively, both in the ileum because they were able to scope right through the anastomosis to find it. And there's no excluded segments of bowel in this case. So malnutrition, though it exists, was at reduced rates. So that was his. And then the SASI is basically a variation on that procedure. It basically took that from a 2 anastomosis operation to a 1 anastomosis operation. And so it achieved similar rates, but you can see instead of doing a division of the bowel, you just bring up a loop and perform 1 anastomosis. But in the same fashion, you do a sleeve and you maintain continuity with the duodenum. And so the SASI also has very good diabetes remission rates, all the metabolic syndrome comorbidities, including hyperlipidemia, hypertension, and sleep apnea. And a little bit better weight loss compared to a standard sleeve gastrectomy. And then there are all the implants. There are many of these. This is not an exhaustive list, but this is an endobarrier. Basically, it's a lining that's endoscopically placed in the duodenum that prevents absorption. And so you place this for a time, and the food travels through the liner. And then once you achieve your adequate weight loss, this liner can be removed. There's the Berry clip, which basically acts as a gastroplasty, but this is done in an operative fashion. And then this is actually the Obalon balloon. It's actually a balloon that you swallow. It starts off as a pill, and then they inject gas into it and inflate the balloon. And then they can actually add multiple balloons. They can go up to 3 balloons, and then after And this obviously works through restriction. And then after adequate weight loss, it's actually all removed endoscopically. So these are the various implants. There are more, but
I think
this
there's
is
other
just kind of,
balloons too.
what's that?
I think there are other balloons too that are used
Yeah,
similar that are either, placed endoscopically, things like that too.
right. And the big advantage they say the Obalon balloon has is that it, doesn't require endoscopy to place, but it's misleading because you need endoscopy to remove them. So it's not really, I think they try to mislead patients a little bit with the marketing on that one. And so
And
that's
and
basically my
we
talk, but yeah,
we actually had somebody come in with that bar clip device that was placed to
yeah,
record. It was really something else. She had
yeah.
the excluded stomach exploded pretty much because it was partially occluded. And with the swallowable three balloon thing, I can never remember the brand name for that. I had one patient, first of all, the BMI was like 60. I don't know what the hell anyone was doing, putting a balloon down this guy, and actually on retrieval had a major esophageal perforation,
Mm.
which was just, as you can imagine, not fun to deal with in a really morbidly obese guy that had lost 10 pounds.
Well, and I think, that kind of brings us to the earlier point of like, when there are endoscopic options, having surgeons involved in that decision making is really important because certainly a lot of times we end up dealing with the complications afterwards. So I think kind of being a part of the decision making and figuring out, patient selection up front, as opposed to just having to deal with it all in the back end too is helpful. Yeah, Barry Clip is a little bit scary to me too.
Yeah. I just thought I'd show them because I'm sure people will start to see these
Yeah,
in
no, absolutely.
their emergency rooms someday, and we're all going to have to try to deal with them. So I'll move on to some case scenarios. And we can kind of talk about what option might be best for these patients. I don't think there's any one right answer, but I think there's unique opportunities with the new advances that have been developed. So this first one's a 45-year-old female, history of asymptomatic gallstones, just incidentally found, hypertension, hyperlipidemia, type 2 diabetes, morbid obesity. She's failed all the conservative measures. She's been able to lose some weight on a GLP analog, but doesn't tolerate the side effects. But she's interested in weight loss surgery.
Yeah, so I guess like kind of looking at this overall stem for this first scenario, what are the things that kind of pop out at you and what sorts of things would you think about in talking to patients?
So, I'd look at her comorbidities. Certainly, she has type 2 diabetes and metabolic syndrome comorbidities. So, I'd like to give her an operation that can help mitigate those, especially a bypass. But what worries me in general for bypass patients is, you lose endoscopic access to the biliopancreatic limb essentially. And there's ways to manage that, of course. You can do an edge procedure or lap assisted ERCP, things like that if you need to. But if you know your patient has gallstones and there's no immediate need to actually address them, do you change your decision making if you have the capability to do it?
I think that's an important question. I think for me personally, when I'm talking to patients, I don't always change my operative approach on with or without gallstones. Certainly, I think when we used to do these operations open, there was a big push to do both operations at the same time because you're
Mhm.
right there in the same part of the abdomen, and so certainly can do it both at the same time. You certainly can still do like a sleeve and a sleeve or a bypass and a cholecystectomy at the same time. And some people will still do that. I think the other option is um, doing the weight loss procedure and then going back in and just doing their cholecystectomy later after they've lost weight when it's a little bit more technically feasible too. But I
Mhm.
think it's more of for me, at least a conversation with patients about the potentials of, or, the potential for another operation or another procedure later and kind of what they're comfortable with.
Yeah.
I guess in the setting of kind of what we're talking about today, is there anything else that you wanted to address too?
I mean, I think because she has the potential of developing complications from gallstones, and at least to manage her acute problems that might happen, that might occur, you could consider doing one of the, the SASI, for instance, or the transit bipartition, only because it maintains access to the duodenum. I think, certainly we have ways of managing this without all that. But I think that as people become more comfortable with different types of operations, it kind of changes your algorithm. So it kind of brings into question, what you can offer patients as these different procedures gain popularity, if they do gain popularity.
I think that kind of highlights the most important thing, which is just kind of going over the potential need for further interventions in the future, or kind of the possibility of having another procedure, or kind of what it means to not have access to the biliary tree for patients too.
Right. So I'll move on to the next.
One other thing to just keep in mind is remnant stomach cancer, which can be really horrendous because we don't have access to that. It's pretty uncommon, surprisingly, because I always worried about that when gastric bypass started out, that this stomach chilling with no growth factors or anything might be an issue, but it's pretty uncommon, thankfully, but so difficult to diagnose. That's the trouble.
Well, yeah, we do know it's relatively uncommon. I don't know the numbers off the top of my head, but pretty uncommon, but certainly something to think about.
Okay. Next scenario I have. So a 55-year-old male, history of morbid obesity, underwent sleeve gastrectomy 6 years ago. He achieved 67% weight loss at 2 years, but now has regained most of his weight. He's only at 10% excess weight loss currently and unable to sustain further weight loss. His upper GI just demonstrates a patchless sleeve, no other abnormalities, and he would like to avoid another operation if possible.
Yeah, so I guess again, kind of same things that kind of stand out to you from this patient.
Again, this is someone who originally did well with his sleeve, but is now regaining weight for whatever reason, whether it's a stretched out sleeve, which is unusual, but can happen. He doesn't want any other surgery if he can avoid it. Certainly GLP-1s are an option. But you could also offer endoscopic gastroplasty in these patients. It's been done in sleeve patients, and they do lose some weight with that, especially if you can demonstrate that their sleeve is, no longer has optimal anatomy.
Yeah, I think this kind of goes back to the conversation we were having earlier about kind of what adjuvant weight loss in the setting of bariatric surgery, or we now are using the term like adjuvant GLP-1s or things like that too. So neoadjuvant versus adjuvant GLP-1s. I think this is certainly a role to try medical therapy to see if that helps patients achieve more weight loss. Certainly worth having a discussion about endoscopic management options. If that's available. And again, a lot of times insurance is a big barrier to that, as most people pay out of pocket. I don't know how
Yeah.
much, potential extra weight loss you're going to have from that, since the weight loss just from endoscopic sleeves tends to be pretty marginal, are not as great in the first iteration, and so may not have as much weight loss again the second time, especially. So it may not be worth it to patients especially if they're having to pay out of pocket for a procedure like that. But
Yep.
certainly something to discuss.
Does
Yeah.
the question of reflux come into your mind in deciding this? Because if somebody is refluxing terribly, I I would go towards, an operative surgery would be a bypass to me,
A
right?
bypass, yeah.
It's such
Absolutely.
a great anti-reflux procedure.
Yeah, absolutely. So I guess this guy had said he didn't want another operation if possible, but certainly we're talking about possibilities for helping achieve greater weight loss after surgery. By conversion of a sleeve to bypass is reasonable. Now, sometimes we don't really exactly know how much extra weight loss they're going to get again after that. It may not be quite as much as what they're hoping for. Sometimes even the difference between sleeve and bypass is only about 10 to 15 pounds, depending on their initial weight. So hard to know for sure. But certainly, especially in the setting of reflux, absolutely, I would recommend a bypass.
Yeah, and reflux is actually one of the listed contraindications to gastroplasty, just because you can't address their hiatal hernia at the same time. So you're just going to make it worse. And next, so 34-year-old female, morbid obesity, type 2 diabetes, complicated by CKD, retinopathy, hypertension, hyperlipidemia, has failed conservative management, will like surgery, but wants to have the simplest procedure done, optimal benefit to her weight and comorbid conditions. So again, this would be an obvious choice for, a gastric bypass. She has type 2 diabetes and is developing complications related to that. So you want something that can really address her diabetes and get her metabolic syndrome under control. And generally speaking, the best operations for those are, a duodenal switch or a SATI. They do a pretty good job at controlling that. So I think those are the two things to consider here. Of course, the SADS is considered a little bit simpler only because it's only one anastomosis, so it's something to consider. But I think surgeon preference and surgeon comfort in performing these procedures is a big decision point, or at least will influence what procedure they'll offer.
I think in patients with even higher BMIs, because I think that's going to be kind of the future of what we're managing from a bariatric surgery standpoint, is certainly think about, possibly doing a stage procedure, doing a SADS with doing a sleeve up front, and then going back and converting them later is another thing to kind of keep in your back pocket as we move forward, particularly in patients where it's really technically challenging to do an anastomotic procedure.
Right.
All right. Well, it looks like we're already over our time. So yeah.
Yep, go ahead. Thank you all so much. I think it's a great discussion. And again, thank you to our international colleagues as well. Thank you so much, Dr. Mustian, for being our moderator this evening. Sorry for my screaming baby in the background right now. And excellent presentation, Dr. Patel. Everyone who wouldn't mind putting your cameras on, Dr. Patel, if you could unshare your screen just so we can take our picture for Twitter. And just a reminder, register for DDW. And our next session will be May 19th and is actually being moderated by our SSAT president, Dr. Volanovic. Topic is paraesophageal hiatal hernias as well. So we're on a bit of a little foregut bariatric trend right now, which I think